So I have been asked to cover mental health, overdose, suicide, alcohol intake, everything in 45 minutes. I am not going to do that. I am basically going to I worked on MAU this weekend, and this is pretty much what I saw on MAU this weekend. So really brief, this is not psychiatry. You've already had psychiatry in fourth year. You'll know far more than I will about psychiatry and the background of these conditions. So it's really basic, all right? So I'm going to cover a little bit about alcohol misuse and dependency, a bit about how you manage it on MAU, a bit about suicide, and cover very briefly, mainly about paracetamol overdose, and a little bit about a couple of others. One slide on dementia and one slide on the Mental Capacity Act. Okay. So alcohol misuse is really, really common. Pretty much the bulk of MAU admissions are to do with alcohol misuse in patients, regular attenders. Basic few facts. There's your units at the bottom, as you all probably know, and none of us stick to those units. But anyway, a few facts about the background of alcohol misuse is quite common. If you've got relatives who are alcoholics, then a sevenfold increase of being alcoholic later on. There's lots of theories to do with positive and negative reinforcement, which can impact. People often have a background of difficult life, so separation, bereavement, job loss, and there's a higher risk in certain occupations, so people who work in pubs, doctors, and unskilled manual social class. And obviously there's lots of comorbidities to do with depression, anxiety, chronic pain, terminal illness. You see it higher in those people. So these are the 7 things which you probably learnt last year to be aware of that makes alcohol dependence officially diagnosed, and you need 3 of these to occur at the same time in a 12-month period. So just reinstating these. So when you see a patient on MAU, take their history as normal, and you need to ask certain questions, and these are the ones that are really important. So you want to know what they're drinking, how much they're drinking, where they tend to drink it. Do they drink by themselves? Do they go out? Most, unfortunately, when you get to alcohol dependence, they'll just drink at home by themselves, drinking 2 to 3 litres of cider, 4 bottles of wine. It's not unusual. And when they drink, so do they drink from the morning onwards? They just drink at night. Some people are alcoholics, but they don't drink until they get home from work, but then they can still drink a huge amount in one evening and feel fine the next day. Ask about features of dependence, so the 7 things from before. You want to know a background on their psychiatric history and their medical history as well. Drug history is really important, especially if they're alcoholics. They'll probably already be on thiamine and vitamin B, which makes you think they've already been seen and assessed by someone. So there might be someone to contact to get them in touch with to help them with their alcoholism. A bit about their social history, so just trying to find out what their risk factors are. So have they got the social framework? Have they got friends? Have they got family? Have they got kids? And then obviously the CAGE questionnaire, which I hope you all know. So ever thought about cutting down? Do you ever feel angry if someone tells you to stop? Do you ever feel guilty about how much you're drinking? And do you ever need an eye opener? Those are just basic things you need to ask. So a bit more important about what you're actually going to do and what you're going to see when patients come in with alcohol dependence. So patients come into MAU, they've normally been found by someone, family member, found on the street by ambulance. By the time they come up to you, you might have a job in A&E, so you might see them first off, but often by the time they come to you on MAU, they are quite aggressive, they're not the nicest of patients, and if they're getting side effects, then these are the first things you see. So they can be tachycardic, they can have hypotension, often got a tremor because it's been a while since they last had a drink. By the time they've got into A&E, they've got to you, they could have been 8 hours without having a drink, so you'll see the side effects. They can become confused and they can feel really sick. And then you start to see more complicated things a bit later on. So 1 to 3 days later, you start getting your classic delirium tremens. This is when they become really confused. They can come in and out of consciousness. They become really disorientated, and that's why they become quite abusive and quite aggressive. They can have memory impairment. They can often confabulate, so their story changes really quickly. They become really anxious. Really strong hallucinations, so you've all heard of the Lilliputians hallucinations, can't sleep, and they can also have seizures. So we see loads and loads of people coming in having had a seizure, and often related to alcohol withdrawal. And then these are the more permanent things are the Wernicke's and Korsakoff. So Wernicke's is a reversible is a reversible complication, and corticosteroids is not. It's permanent, and it's also to do with thiamine deficiency. So this is when patients, you'll see, Raj would have seen all the time on the gastro ward, really confused, often got a funny walk, they have a bit of a drunken walk, ocular palsy, and about only 20% recover. And if you get corticosteroids, it's permanent. And the way to reverse it is by giving them thiamine. And then, as Raj has covered, you've got the chronic misuse patients, so fatty liver, alcoholic hepatitis, and cirrhosis. So how are you going to manage them? So as much as you don't want to manage them, it's really important to. Chlordiazepoxide is what we give to for symptom management. On MAU in Leeds, so it depends where you work, but on MAU in Leeds, and so the charts that you will obviously have in your exams, there's really good, easy charts. You don't even have to think about it. So patients who are coming in as regular attenders who have got a known chronic alcoholism, you often put them on a reducing dose of chlordiazepoxide. It's on the guidelines. I'm not going to tell you what it is, but basically you give it 3 times a day for a couple of days, then 2, then 1. It's really simple. Or in Leeds there's a chart called the SIWA chart, SIWA, and you basically just sign it. The nurses then, when they go around to see the patient, they just look, they grade their symptoms, so if they got nausea, if they got headache, if they're confused, depending how many points they get, depends whether they get any chlordiazepoxide or not. So that's really, really easy, but that's roughly your doses. You start with 10 and go up depending on how they're managing with their symptoms. And the most crucial thing is where you get them on IV Pravanex as soon as you can, because that's going to stop them having those irreversible side effects of Wernicke's and the corticosteroids. And they have 3 bags of Pravanex in a day, and depending how long they stay, depends how much they get. So that's the most crucial thing that you can do. Get them chlordiazepoxide. It's going to make your life a lot easier. It's going to make the patient's life a lot easier. It's going to make the other patient's life, and it's going to make the nursing staff a lot happier, because they will be easier to deal with. And then from there, when the patient's more stable, wanting to go home, LAU, which is Leeds Addiction Unit, you send a referral to if patients are interested in stopping drinking. You obviously offer it to all patients, but not all patients are going to take you up on it. And organisations such as AA, and then we send everyone home with oral vitamin B and thiamine, so you take those 3 times a day. Unfortunately, they don't often take them. And then LAU and other organisations start people on disulfiram, which is the drug that makes you have really unpleasant side effects when you take it. And unfortunately, you see a lot of people come in who are on disulfiram and then drink, and they come in really, really poorly. So it's really important to tell them, if they are going to drink alcohol, do not take your disulfiram, because you will be in hospital and you will be really poorly. And ideally, they need to stop taking it a couple of days before they're going to drink as well. So, on to more cheery subjects. Suicide. That is the definition. You probably are not going to see much suicide, but you will see a lot of attempted suicide or parasuicide, so acts that look like suicide but do not result in death. Their intention may have been death and it's failed, or it could be an attention-seeking activity. In the UK there's about 5,500 suicides a year, and it's the leading cause of death in young people. You've probably seen on the news recently a huge increase in suicides. It's really sad. And completed suicide is a lot more common in men. So what are you going to ask these patients? So they're on the ward, they've come in with attempted suicide. These are the key questions you need to ask. You need to ask, why? Why did they do it? Why that day? Had it been planned? Had they been thinking about it a long time? That's obviously much more worrying. How had they done? What they've done? And more details about that. Had they left a note? So that obviously makes it more concerning that they've thought about it for a while. Anyone around? Anyone who found them? Can you get any information from them? Did they drink any alcohol beforehand? Obviously that mind could be skewed, or it affects your management later on. Did they try to seek help? Was it them who called the ambulance? Did someone else call the ambulance? What made them do that? And how are they feeling now? Did they regret their decision? Do they wish they were dead? Kind of thing. It's not nice, but it's important to ask about. You also need to ask about risk factors. So males are more high at risk. Age as well. So like I said, young people and older people. And then life things as well. So have they recently become divorced? Have they lost their job? What's their socioeconomic status? Who they've got at home? Who have they got to look after them? Who do they talk to? Have they got any history of self-harm? Have they ever been admitted before with a previous attempted overdose? Any history of mental illness? Any history of physical illness? So patients who've got a long-term chronic illness more likely to try and attempt suicide, and family history as well, much higher in families whose family members tried to commit suicide as well. Mental state examination, which you'll all be dab hand at by now, and what their plans for the future. Have they got something to look forward to? So protective factors. Do they plan to try and do it again? Obviously, they're not always going to be honest with you, but it's important that you've asked and you've documented it. And then when you go from there, kind of depends on what they've done. So you're not going to be the one making the final decision to discharge anybody. So you discuss with your senior, often get psychiatry involved. In Leeds there's the ALP service, which is the Acute Liaison Psychiatry Service, so anyone that's come in having tried to take their own life will be seen by them before they go home, and they'll assess their risk for future and whether they're going to have any input when they go home. And then in terms of what you're going to do, wound management, so if they've tried to commit suicide by that, then that's important, and then overdose treatment, which we're going to go on to discuss. So paracetamol overdose. Really common. Most widely used painkiller in the UK, really readily available. It's in loads of different preparations, and it's the commonest drug overdose. But it never kills people, hardly ever. 130 approximately a year, and about 15 liver transplants a year. But you see people come in every single day. So often people come in because it's not worked, because it doesn't work, and they regret their decision. So when you see a patient, initially when they come in, less than 24 hours after overdose, they often haven't got any symptoms. They might feel a bit sick, they might be sick, but other than that, they probably feel all right. More than 24 hours after their overdose, they might show signs of liver failure, which probably is really incorrect after what Raj has just talked about, but they might start complaining of some pain, and you might see some changes on their blood tests. And then 3 to 5 days later, they either recover because they haven't taken enough, or they go into full-blown hepatic failure with the classic symptoms. And so when you see these patients, you're going to do standard approach, just as you would anybody else. So A, B, C, D, E, really important to get some bloods, full blood count using these LFTs, coagulation screen, gives you a baseline bloods and then allows you to compare when you're a bit later down the line. And then you almost always take salicylate levels with paracetamol levels, just because they're commonly in the same preparations, and blood glucose. Often when the patients have come up from MAU from A&E, but even if when you're in A&E there's access to tox space, so they often come with a list of information about the overdose and management and what symptoms would be, which is really useful, and if you ever get a chance to read them, that's really good. And then history. Same again, so when, what, how much, why, have they been drinking, what symptoms they had, were they sick immediately afterwards, and then same again, psychiatric, past mental history, drug history, social history. When you're taking this history, it's really important to get specifics as well. Sometimes patients can be really dismissive, and it's easy just to be like, oh, they took some paracetamol, but we really need to know how much they took, when they took it, with what, and if it's over the counter, exactly what it was, so you can gauge how many grams or whatever of paracetamol they've taken. Paracetamol level ideally needs to be taken 4 hours after their overdose. Often that will have already been taken, but if it's not, make sure it is taken at 4 hours. And you've probably all seen this before, so this is the nonogram, which is in one of the first few pages of the BNF. There used to be 2 treatment lines on for high-risk patients and low-risk patients, or normal patients, which include high-risk patients for people like epileptics, but that's been removed now, so it's just the 1 treatment line. So really self-explanatory, time along the bottom, you get your level after 4 hours and you see whether it validates treatment. If they've had a staggered overdose, so if they've come in and been taking paracetamol every 2 hours for the past couple of days, it's really difficult, and often the level isn't reliable and you treat anyway. So treatment is N-acetylcysteine, basically just replaces the substrates needed for the liver to get rid of all your toxic metabolites. So paracetamol, when it's broken down, can be really toxic, and I think it's glutathione that is needed to conjugate with the toxic metabolites, so it can be excreted, so it's not dangerous to the liver. And this is your treatment. I don't expect you to remember it, and again, there's a really nice chart in Leeds, you just sign it, and the nurses work it out for you. But basically, if patients are going to be put on N-acetylcysteine, then they're in for at least 24 hours pretty much. So make them aware of that. Often patients will start their NAC, feel better, and then be like, I want to go home. And they can't. They've got to stay for the last bag, which is 16 hours. If patients have come in and they've taken a significant overdose, so we're talking, 150 milligrams per kilogram is significant. So I think if patients, so this classic 70 kilo man, if they've taken more than 20 tablets of paracetamol, then that's significant. That could do damage, which isn't actually very much, and it's really easy to get hold of. If it's significant and you haven't got the level, you treat. If it's staggered overdose and you can't quite work it out, you treat. Okay, any questions about paracetamol? It's really, really straightforward. So aspirin, again, can be quite common. It's in a lot of other products. Lots of people are on aspirin, easy to get hold of. I've highlighted tinnitus because if you get a question on aspirin overdose, they will have tinnitus. It's just typical of aspirin. I didn't remember all those questions that Raj was talking about, but I do remember we had a tinnitus aspirin overdose, and I was racking my brain. I was like, tinnitus, I know that's something. It's aspirin. Again, ABCD approach. Aspirin, the effects are dose related, so it's pretty black and white. Over 150 milligrams per kilogram is mild, and if it's over 500 milligrams per kilogram, then it's severe. Aspirin is a weak acid, and it can cause a metabolic acidosis, so you need to do ABGs on these patients. I've never treated anyone with an aspirin overdose, but you need to start urinary alkalization, so you just give them bicarb slowly and monitor their urinary pH, so just with urine dipped, and monitor their ABGs. And most likely they probably would have taken some paracetamol as well, so you probably treat. And if it's really bad, then dialysis. But again, I've never seen that. These are really brief, I'm sorry. An opiate overdose. I don't think you'd see overdose very much, but you will see it commonly in hospital, patients who are on morphine and we've just given them too much, we've miscalculated, or they're on PCAS machines and they're supposed to not let you have overdoses, but patients do. And they become really drowsy and you'll get called to go and see them. So symptoms, constipated, nausea, vomiting, drowsy patients, always think, have a look at their pupils, pinpoint classic signs, can't go wrong. ABCD approaches, again, just to rule out other things, don't be blinded just because you know they're on opiates, you've got to think of other things. Take bloods, take paracetamol level, and then you need to give naloxone. If you're not sure about doses and things, it's always pharmaceutical and they're really, really useful, but you give it really slowly because they will respond quickly to it, and if they don't, you'll know about it quite quickly. But if you give them too much, then they come out of their overdose, especially patients who are on PCAS machines, then you're going the complete opposite direction. They're in loads of pain, they go tachycardic again, they're screaming away, and you backtrack, so you just made more work for yourself. So just go slowly, give a little bit, come back in a couple of minutes, see how they're doing, come back in a few minutes and give them some more, and just go slowly until you start to see a response. And then obviously titrate their morphine or their opiate level back down. You can always give more, so reduce their regular morphine, and you can give Oromorph as a PRN, and then the nurses can just give it, and you can titrate that up. So don't be afraid of reducing it and just giving them some extra for breakthrough pain, and the nurses will ring you if they need more. Dementia, really common, see it loads, unfortunately. Over 25% of all hospital beds have got patients in with dementia. It's just something to be aware of. I've just come off elderly, so I guess it's kind of front of my mind. Causes loads and loads of different reasons, as you probably are well aware. So just when you're seeing patients in hospital, the diagnosis is rarely made in a hospital. It will say at the back of people's mind, but often you put on discharge summaries, please refer to memory services, likely got dementia, but you can't make it in hospital because it's an acute setting. You need them to get over whatever acute illness they've come in with. So when you're seeing these patients, you need to do an AMTS. In Leeds, we've got these things called sequins. I don't know if you've seen them, but they're green forms. Every patient over 75 has to have them done. They have an AMTS on admission and an AMTS on discharge. And then that allows us to see whether they need to refer to memory services. MMSCs, if you're an elderly, you'll be doing them every single day. And then these are the confusion screens. I just thought it's quite useful to highlight. So any patient who's elderly, who's come in confused, you need to put these bloods out. So full blood count, user needs, LFT, CRP, magnesium and phosphate, calcium, TFTs and hematinics. Just do it. Any patient over 75 come in confusion. It's really easy. It's just a yellow bottle, a purple bottle and a blue bottle. And you've done it. Well, you don't actually have to do blue, but everything comes out of that yellow bottle, and it's really useful, and at least you've got their baseline, and at least you know a little bit about what you're talking about. MSU on every patient, chest x-ray, and then a bit later down the line, CT head. Often on elderly they'll do CT head because for a diagnosis of dementia in the community they need to have had a CT head, so often they'll do it for patients when they're in. And then in terms of management, you're ruling out delirium, so ruling out any causes of infection, and then refer to memory services, and those are a couple of drugs you might see on drug charts, so donepezil and memantine. They don't stop dementia, but they help slow down the progression, so often you'll see patients on those, so it makes you just think. But yeah. And then my last couple of slides, I'm really sorry, really boring, but Mental Capacity Act. Sometimes as the F1 you're going to get asked to go and assess someone's capacity, so it's quite useful just to know what you're talking about. So you probably all know, so it's an act that allows people to make their own decisions, allows them to make slightly weird decisions, it's got their best interests in heart, and always takes into account the least restrictive intervention. So if you get asked to go and assess someone's capacity, then these are what you need to think about. Do they have any underlying kind of delirium or encephalopathic from liver disease, or under the influence of any alcohol or drugs that could be affecting their decision-making ability? And then the four key questions. Can they understand the information? Can they then retain that information? Can they use that information to make a decision? And can they tell you what they mean? And you need to do everything you can to facilitate this. So if there's a language barrier, you have to get a translator. If they're deaf or blind, then you need to do your best to make sure that they can fully understand the information. You need to do this on a decision-wise basis, so every new decision you have to take into account separately. Okay? So just a couple of scenarios, really quick and easy. So 47-year-old male, admitted a bit after being found on the street by ambulance staff, on the ward is becoming really loud, verbally abusive towards staff and patients. He's got a background of alcohol excess, comes in all the time, he's got hypertension. Those are his obs. Are we worried about those? Yeah, SAT's a little bit low, but no, basically no, we're fine with those. And his bloods, are we worried about those? So he's got a little bit of a low HB for a man, but he's got a raised MCV, so often patients who've got chronic alcohol intake have got a macrocytosis anemia, so that's probably related to that. His LFTs has got a bit of a high ALP and a bit of a high ALT and bilirubin, but nothing overly concerning, as INR's fine, fits with the history. So in terms of management, like I say, priority is making sure the patient and the staff are safe, which is often a bit of a nightmare on MAU. Prevent the irreversible causes, so get them on IV Pabrinex, get them on some chloride epoxide, refer to LAU, and make sure they go home with oral vitamins. That is pretty much the extent of what you're going to do, and they will be back in next weekend. Sorry if I sound cynical. This patient I actually saw this weekend, so she was a really nice lady, 65-year-old lady, came in after taking ibuprofen and paracetamol every 3 hours for 3 days because she had really bad dental pain. She couldn't get to the dentist until Monday. Are we worried? Yeah, that is more than you should be taking. Every 3 hours taking paracetamol for 3 days is definitely more than you should be taking. She wasn't aware of this. She just wanted to get rid of the pain. She's got a background history of diabetes, hypertension, she had a cholecystectomy, so nothing remarkable. Her obs are pretty stable, nothing to worry about, and her bloods were completely normal, and her paracetamol level was 22, which if you look at the nonogram is below treatment line. But you don't know when your start level of the overdose was. You can't really estimate what that level means. You can't interpret it. So we started treatment. So she went on to NAC. She had the 3 bags. We repeated her bloods after she finished her bags, and her bloods were fine. Then she wanted to go home. It was Sunday evening, or Sunday morning. She had a dental appointment on Monday afternoon, and she was really worried about what she could do about her pain, and wanted some painkillers to go home with. She was really sensible. She understood that she'd taken too much paracetamol. I wasn't worried about her, there were no risks, so what analgesia would we offer instead? Aspirin? Yeah, yeah, so you just work up your pain ladder. So she could have paracetamol. We've given her the treatment. There's nothing wrong with her having that, but the paracetamol obviously wasn't working. She was having to take it three hourly, and the poor woman has been in hospital all weekend. She just want to get some sleep. So work up your pain ladder. So we gave her codeine. She felt really sick. So then we gave her tramadol, and she had an awful reaction and was vomiting and had a raging headache. We'd already discharged her. She was just sitting in the waiting room to go home. We'd given her bed up because there were people queuing in the corridor. Anyway, she sat and she was fine, and we gave her, in the end, we just gave her 4 doses of ibuprofen to have over the night, and she was okay, and she went to see a dentist. So, just quick conclusion, really, 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 really common. It's really, really boring, but just approach it in ABCD manner. Start Pabranex if you're in doubt. You'll have never done the wrong thing. Paracetamol overdoses is really common. Don't be afraid of starting NAC. Consultants will stop the bag. So if they don't want you on it in the morning, they'll just stop the bag, and you've not done anything wrong, you've not harmed them. If you can wait for their 4-hour levels, do. If you know exactly when they took it, wait. And just be aware of other drugs. I think in your syllabus there's something about tricyclic antidepressant overdoses and stuff. I'd glance at them, but I wouldn't worry about it. And just know the basics of Mental Capacity Act.